Let's talk about agents that we've seen, top-line data that we've seen with combinations of therapies where maybe we're seeing some benefit on anemia or at least lessening of anemia that we'd expect with JAK inhibition. Maybe Gabby, you could start with what caught your attention.
Yeah, so last year obviously we were all very excited for having 2 phase 3 studies that were presented at that time, and pelabresib, we didn't hear that much about it this year, but we certainly heard of other BET inhibitors, the Insight compound. And I think there's definitely a signal there, both in monotherapy for pelabresib and the Insight BET inhibitor, that it's anemia friendly. There's definitely a signal that it can help improve hemoglobin in those patients. So that's definitely something that's caught my attention.
We did present the updated 48-week data in a poster at ASH 2024. So showing that you can maintain spleen and symptom benefit over that 48-week period. Of course, that's still kind of short. We got to continue following the patients. But what I think still holds true is that delta between the 2 arms in terms of the hemoglobin, mean hemoglobin levels, continues. So you get like blunting of the anemia that you expect. That's pretty predictable with ruxolitinib. And then, and then the sense that you maintain that and even improve it over time with pelabresib, in which, again, anecdotally, for whatever it's worth, I do have patients long-term now that have been transfusion independent on that drug too. So I think it's interesting and it's helpful to get a sense like when we combine these drugs, other than deepening spleen and symptom, are we also offsetting things like anemia? And for that matter, any other data that you've seen combination-wise that's looked good for anemia?
Yeah, I mean, I think certainly the Pella data, I think, is probably the most exciting from the combination data. And seeing the long-term outcomes, I think, is going to be really important for any combination, right? We have to see durability in that. I think certainly the Naseema Gangat presented this meeting, the DISC agent, right? And that was both in combination as well as a single agent. I believe it's DISC 0974. And starting to get a decent amount of patients on that study. Most of them enrolled at her center, so she was able to speak to her experiences with the agent. Seems to be very few AEs that were reported out negatively with that agent, and really impressive kind of anemia responses in both transfusion requiring and patients that were just anemic but not requiring transfusions. And I think that that's another one that's targeting that kind of hepcidin pathway by being a monoclonal antibody that hopes to kind of decrease and downregulate hepcidin and allow for better iron utilization. And so, I think the question that I have a lot with these agents is, are they there to kind of restore anemia? Is there a prognostic benefit of making that better? Or is there a prognostic benefit in allowing full dosing of a JAK inhibitor? Are we using these in isolation? Are they always going to be combination partners? I think that one thing that comes up, and I know there's ongoing studies looking at it, is, okay, well, if Pella is able to blunt the anemia response or the detrimental anemia effect of ruxolitinib, what happens if you use it in combination with momelotinib or pacritinib and luspatercept? The potential of combining that with other agents too is attractive. So
to that point, one data set that I think is intriguing is if you look at the Simplify data, more so than a Momentum where they had crossover, but Simplify, which was momelotinib versus ruxolitinib, Simplify 1 in the upfront setting. They did a nice analysis that actually would correlate anemia improvement with overall survival. And that's actually the first time I've ever seen that. So speaking to your point, that maybe improving anemia, not just removes that negative, but it maybe even improves the outcomes of patients. And in that case, it's probably not necessarily linked to spleen reduction because the other arm had spleen reduction. The people who didn't get the anemia did still have the spleen reduction, and that didn't seem to drive it. What about maybe less focused on anemia, but what other combinations, novel combinations, do you think are potentially promising coming out that will read out?
Yeah, I mean, probably the most exciting one right now, and that's in late stage development is going to be with selinexor, right? And so we've seen kind of early phase data showing remarkable response rates with ruxolitinib plus selinexor. Certainly selinexor is not a new drug to us, right? It's been used in a lot of different indications, but at different doses, right, with different tolerability profiles there. And so I think there's a lot of curiosity with that study, not just to see kind of what the response rates are going to be, but how's the tolerability, and then also given kind of what we saw with Pella and navitoclax last year in terms of that symptom issue is how is that going to be impacted, and is the tolerability going to be something that hurts that, right?
So selinexor I think is an interesting drug, and I think mechanism of action wise, activates P53, downregulates NF-kappa B, also indirectly affects JAK-STAT signaling and other pathways that are probably relevant to the pathobiology of the disease. So you can appreciate where this drug would have activity. And then activating P53 is a theme, I would say, at least in MF that's caught on. And the drug that I think has been most impressive in that way has been navtemadlin, the oral MDM2 inhibitor. From the Boreas study, we presented results here at ASH, both looking at the clinical outcomes as a single agent in the JAK inhibitor relapse refractory setting, but also as a combination, well, the POESIS study, I should say, is going to be a combination study that's activated, global trial, randomized phase 3. Interestingly and sort of innovatively, taking patients who are JAK inhibitor naive, so characterizing them at baseline, spleen, symptom, et cetera, following them for at least 18 weeks, and then suboptimal responders are the patients that can randomize to the addition of navtemadlin, same dose and schedule as single agent in the relapse refractory setting, and then placebo as the control arm. So looking to see, can we move navtemadlin, which has shown clinical activity, spleen and symptom reduction as a single agent in the relapse refractory setting, up earlier as an add-on strategy.